Hello and welcome. I'm Dr. Virginia Hubbard. I'm a consultant dermatologist at Homerton University Hospital in London and a clinical senior lecturer at Bart's London School of Medicine and Dentistry. I'm now going to cover 5 questions related to the MRCP Part 1 dermatology questions. So the first question. A 25-year-old man presents with bilateral ankle pain and swelling. He has raised red lesions on both his shins. He is usually fit and well and works as a lawyer. The only history of note is a pharyngitis, which preceded the symptoms. And the investigation results are listed here. So here's the question. Which of the following is the most likely clinical outcome? And I'll give you a minute or so to answer. So the correct answer here is A, spontaneous resolution. And to get this one right, you have to know the diagnosis. So the diagnosis in this question is erythema nodosum. And the features in this question that make it erythema nodosum are that the patient is young, he's got a painful rash, and it's nodules on the shins. The fact that he had a preceding pharyngitis is the icing on the cake. The fact that he's a lawyer is completely irrelevant to any dermatology problem. So, erythema nodosum. Well, it typically affects young adults. It is more common in females, but it affects men as well. And it involves tender red nodules, and it's usually over the lower legs. And it's often accompanied by a fever and arthralgia. And here we can see typical pictures of erythema nodosum. So there are tender red nodules on the lower legs. And erythema nodosum is a paniculitis, and that simply means inflammation of the subcutaneous fat. And the etiology of erythema nodosum involves infection, such as streptococcal infection, which was probably the trigger in this patient, TB and leprosy, various drugs, inflammatory bowel disease, sarcoid, Behçet's, and pregnancy. And the investigations that you would want to do would be a chest x-ray to look for sarcoid or TB and an infection screen. Now back to the question, the treatment. Well, most of these cases resolve spontaneously. So the patients need to have bed rest, analgesics such as non-steroidal anti-inflammatories, and the erythema nodosum usually settles in weeks to months. Okay, so the second question. A 44-year-old woman has been admitted to hospital with atypical pneumonia. She has now developed a rash with a purpuric centre. There is no mucosal involvement. What is the diagnosis? And I'll give you a minute to choose your answer. Well, here the correct answer is erythema multiforme. And we'll move on to why it's erythema multiforme in a minute. But erythema nodosum typically produces tender red nodules on shins. Hereditary pemphigus, well, the patient's a bit old for this, and also pemphigus typically involves the mucosal membranes. A fixed drug eruption would produce an isolated scaly patch, so again, not typical of this history at all. And toxic epidermal necrolysis is where the whole skin sheets off because of necrosis of the skin, and there is always mucosal involvement there. So, erythema multiforme. Well, here we have target lesions with a purpuric centre, as in this question. Stevens-Johnson syndrome is a part of erythema multiforme, but there is mucosal involvement as well. So as you can see from this slide, erythema multiforme is a spectrum of disease. On the top left picture, we can see the typical target lesions, and these are involving the palms and the soles. And so we often describe this as an acrally distributed rash. and below that you can see the typical purpuric centres of the target lesions. The next picture, in the middle, is of Stevens-Johnson, and this is erythema multiforme with mucosal involvement, and you can see here that there is some crusting of the lips. And then finally on the right, the most serious of this spectrum of disease is toxic epidermal necrolysis, and this is when the whole epidermis of the skin sheets off and there's mucosal involvement. So what causes erythema multiforme? Well, like many rashes in dermatology, the top two causes are infection and drugs. So out of the infections, herpes simplex virus and mycoplasma pneumonia. And in this question, the patient had an atypical pneumonia, so we can presume it was mycoplasma pneumonia. But also drugs are an important cause. And the treatment of erythema multiforme, well, if it's caused by a drug, that needs to be stopped. Any underlying infection needs to be treated. And if it's severe, and this is typically for patients with Stevens-Johnson or toxic epidermal necrolysis, the patient will need supportive management to prevent heat and water loss and may need oral steroids. So on to question 3. A 28-year-old woman presents to the dermatology clinic with 2 well-demarcated bald areas on her scalp. She has a past history of autoimmune hypothyroidism, but a recent TSH measurement was within the normal range on thyroxine therapy. In addition, she has type 1 diabetes. On examination, the affected areas of scalp look normal, and there are no signs of inflammation or scarring. Hairs removed from the margin of the bald area look like club hairs. So, what diagnosis fits best with this clinical picture? And you'll have a minute or so to answer. So the correct answer here is B, alopecia areata. Now all of these answers cause hair loss, but we'll see why in a minute, why alopecia areata is the best. So alopecia areata, as we can see, causes discrete areas of hair loss. Of importance, there is no scarring, so the scalp skin, as you can see here, looks normal. And the cardinal sign of alopecia areata is exclamation mark or club hairs at the periphery, and here on the right is a typical picture of some club or exclamation mark hairs. Alopecia areata is common and it's recurrent, and there is a link with other autoimmune conditions such as vitiligo or thyroid disease, and sometimes the patients will have nail changes with pitting. The treatment of alopecia areata is usually with potent topical steroids, but sometimes we will use intradermal steroids by injection as well. And if there's a very rapid onset of alopecia areata, a short course of oral steroids can be helpful. Unfortunately, some patients who get very progressive alopecia areata do resort to wigs. So, other causes of hair loss? Well, we divide them into those that are non-scarring, including alopecia areata, and those that are scarring. So as we can see here at the list on the left, non-scarring causes include a low ferritin, thyroid disease, drug-induced, telogen effluvium, that's the typical hair loss that can occur after a stressful event or a patient has been unwell or had surgery, androgenetic alopecia, and trichotillomania, when a patient pulls their hair out. And then these are very different to the causes of scarring hair loss, which include discoid lupus erythematosus, which is shown here in the picture, and lichen planopilaris. So going back to that question, the fact that there was no scarring and that they were discrete patches of baldness makes the diagnosis alopecia areata, and that's before you even know that there's an underlying autoimmune thyroid problem. So on to question 4. A 22-year-old woman presents with an intensely itchy rash, particularly affecting her scalp, buttocks, elbows and knees. The lesions formed are either papules or blisters up to 1 centimetre across, and intense itching can predate the appearance of new lesions by a few hours. She has also suffered from diarrhoea, which has waxed and waned over the past few months. The GP suspects the rash may be dermatitis herpetiformis and arranges a skin biopsy. which of the following immunoglobulins is likely to be found on immunostaining of the skin sample? And have a minute or so to answer this. Well, the correct answer here is IgA, and this is one of those things that you either know or you don't know. But dermatitis herpetiformis seems to be a really favourite question amongst the MRCP Part 1 exam. So, dermatitis herpetiformis, well, it typically forms very itchy vesicles, blisters or papules. And as we remember from this question here, the intense pruritus or intense itch was definitely a feature. Dermatitis herpetiformis affects the elbows, buttocks and knees, again as in this patient, and may be associated with diarrhoea. The patients are gluten sensitive and there is an association with celiac disease, hence the association with diarrhoea. But there is another link to autoimmune conditions too. So here we see a typical picture of dermatitis herpetiformis, and we can see over this patient's buttocks that there are the typical erythematous papules, and this patient had similar lesions over the elbows and knees. And there are really very few rashes that cause such intense itching of papules in this distribution. Other rashes that can cause a problem in this area would be perhaps psoriasis, but there of course you wouldn't get itchy vesicles or papules, you would get discrete plaques with an overlying silvery scale. And in dermatitis herpetiformis, when we look at the skin under the microscope, we see subepidermal blisters and the all-important IgA deposits on immunofluorescence. So how do we treat dermatitis herpetiformis? Well, we've already said that it can be gluten sensitive and can be linked to celiac disease, so the patient should be put on a gluten-free diet. Another drug that can be of use is dapsone. Now sometimes a question may say, what is the best initial treatment to get rapid resolution of the skin lesions in dermatitis herpetiformis? Well, a gluten-free diet is important, but it's going to be slow to help the resolution of the skin lesions, whereas dapsone will be the quickest. So if you were asked that question, which is the most important initial treatment, then it would be dapsone. Okay, and on to question 5 now. A 65-year-old woman presents with a tense blistering skin rash, which predominantly affects the flexural surfaces of her arms and legs, and she has some blisters forming on her torso. She has never had blisters inside her mouth. On examination, she has a number of bullae, more severe on the flexor surfaces of her arms and legs. There are no visible oral lesions. She tells you that the blisters usually heal without scarring. Her investigations are listed here. And a skin biopsy showed a subepidermal blister with a polymorphous inflammatory infiltrate with a predominance of eosinophils. So, which of the following is the most likely diagnosis? So the correct answer here is bullous pemphigoid. Now it's not going to be pemphigus because pemphigus typically causes oral or mucosal lesions, and we know that this patient had no mucosal lesions. Erythema multiforme causes target lesions with a purpuric centre, typically caused by either infection or drugs. Epidermolysis bullosa is a genetic inherited skin disease that usually presents in early childhood. And dermatitis herpetiformis causes itchy vesicles or papules on the elbows, knees or buttocks. Now bullous pemphigoid is the right answer here. So bullous pemphigoid, as we can see from this slide, shows tense bullae, and we can see these in this picture here. There's usually no mucosal involvement, and the blisters are tense because they're forming at the region of the subepidermis. And if the patient has immunostaining or immunofluorescence, it shows IgG and C3 at the basement membrane. Now typically patients with bullous pemphigoid are itchy, and that's different to patients with other autoimmune blistering disorders like pemphigus vulgaris. In bullous pemphigoid, they may be itchy for sometimes months before the onset of the rash. So pemphigus vulgaris was a wrong answer, and this is important to distinguish between because these are superficial erosions, as we can see here on this picture. And as I said, the patients will get mucosal blisters. So if you see a question that involves superficial erosions and blisters of the mouth, then think much more of pemphigus vulgaris. And the blisters in pemphigus vulgaris are much more superficial, and you can appreciate that from this picture. And that's because the blistering is at the epidermal level. And immunostaining will show this because it shows IgG in the intracellular substance at the epidermal level. So that completes the questions for the Dermatology MRCP Part 1. I wish you all the very best with your exam, and I look forward to seeing you for the MRCP Part 2 questions.